You're almost there. You might be there. So now let's bring up Dr. Julie Hayden, and she's going to kick off our program.
Thank you. Okay, how's my sound even in the back? Carlos, how are we doing? All right, very good. So I think most of you here, if you're here, you know a little bit about me already. And I'm a licensed psychologist and work with addiction, mental illness, and homelessness for many years. I've also been collaborating with many people in this room for many years. And I think San Diego's amazing. And I love it. And I have no interest in moving. You know, people keep saying it's expensive and leaving, but it's beautiful. And one reason I'm here is because when you look out the window, you remember, oh yeah, San Diego's beautiful. And I want you to remember that because we need you to be encouraged and hopeful and have perseverance and diligent beyond what you thought was possible. But guess what? Many of the lived experience in this room had to do that already too. So they came against all odds, probably a story that you couldn't even believe was real, and you're going to hear about that today. And they did that to get on the other side for the life that they wanted. So if we put a little bit of that energy and perseverance and diligence and hard work, I think that's just great. I'm ready for it. Anybody that knows me knows I'm ready for hard work, and I know many of you in this room and what you've sacrificed in your life to give to others. And that's what it's all about. This room right here, and there's many, many others that couldn't be here today or maybe even on Zoom watching us that are a part of this, that want this for San Diego, to decrease the homelessness. I want to say functional zero because it sounds cool, but I just wanted to go down, 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 down. So we're going to start there with that decrease street homelessness. Not just because those who are homeless are on our streets and it impacts San Diego in many, many different ways, but also because they're human lives. And people try to figure out why I have hope, why I have energy, why I have encouragement. And the main reason is because I've watched the person that everybody gave up on, that you thought, even I thought, there's just no way. And they came out of it. And they don't just barely make it, they live amazing lives, connected to their family, connected to their community, giving back in ways that I can't give back. And there's many in this room that I know are of that, and that's why I have the hope. So not my real speech, but I want you guys to be encouraged and ready for this. Because as I do this, we're going to talk about the White House, we're going to talk about national and federal, and sometimes people start cringing on me, like, ooh. Because there's not everybody agrees on everything. But what we do want is the same goal. So if we have that vision in front of us, and then we allow for different points of view and different ways to handle the situation, but come together as a team, that's when we're going to see something amazing happen. So this is called Homelessness Solutions Collaborative. We're here in San Diego, but we have Imperial Valley represented. We have Los Angeles represented, not physically today. The LA Sheriffs didn't come, but they wanted to be here, and we're going to keep having that collaboration with LA as well, and anybody else that will do it. People want to collaborate. It's an open table to come have a seat. We created this. You helped me create this because San Diego does not lack people who care. We do not lack great, amazing, committed organizations, innovative programs, and significant resources. What we sometimes lack is a shared pathway, a way to connect those resources to people so they don't just move from one program to the next or from one crisis to the next, but they have a genuine opportunity to transform their lives. This is an especially important time right now because last week, we had the White House Office of National Drug Control Policy, Department of Health and Human Services, and the Department of Housing and Urban Development release the new Best Practices Toolkit you have on your table. I was able to go to the White House and share our model, the Rhombus model we use at ECTLC, Genesis, Rhombus, New Vision, some other organizations, teaming up now with Serene Health. We were able to present this at the White House, and what they were asking is, what's working? What type of changes could we make where it's basically tied to funding? Because that's the power. So we're going to fund you if you give us what we're looking for, and this toolkit describes it. If you come open-minded to this toolkit, I think you'll love it. It's amazing. They did a great job. They have a good outcome here. And what they're looking for is not the person to go just one step, but all the way through to self-sustainability. They also do account for not everybody can take care of themselves the same. So we still need permanent housing for those that can't. But what they're looking at is if a person could, do we give them the chance? Do we give them the pathway? Not make them go find it. We put it right in front of them so they could easily find the pathway to get self-sustainability in their life. The toolkit represents an important shift in how our nation approaches homelessness. It recognizes that housing is essential, but housing alone is not enough. If someone is living with untreated mental illness, addiction, trauma, or just years of being disconnected from employment or community, simply handing them a key does not address everything that brought them to that point or give them the path to a self-sustaining life. The toolkit calls for a comprehensive continuum, beginning with outreach and engagement, continuing through stabilization, individualized treatment. I'm going to highlight that. So treatment first, I cringed a little bit when I first heard it because I'm trauma informed, and so you don't say treatment, all the time because the person, you're looking at whole person care, you're not looking at broken being fixed. But individualized treatment, I love it. Every person has a different story, and you need to approach every person from a different way, and that's why I need all of you. All the methods that are being used are going to be needed. We just got to line them up in a way that everybody can reach those services easily. The vision that is in this toolkit matches very nicely with our continuum in the Rhombus model. Protect, prepare, propel. Protect means responding to the immediate crisis. It means getting someone off the streets into a place of safety. It means crisis stabilization, sometimes psychiatric emergencies, sometimes addiction treatment, might need protection from violence. We have the DA today, and that's what she's all about, protecting those that need it from violence. Many other things, but that's a key thing I think of when I think of her. Establishing enough trust that a person is willing to accept help. Those are our outreach workers, right? First time you go, they don't want help. Do we give up? You have to build the trust so they're ready to get help. Prepare means that helping the person heal and build the internal and practical resources needed for lasting stability. It may include individualized treatment, recovery support, medical care, life skills management, relationship skills, education, job training, rebuilding healthy relationships, and it goes on and on. They need it all. Propel means helping the person move forward into employment, stable housing, self-sufficiency, leadership, and a meaningful place in the community. This is how we have long-term recovery. Some of my recovery people in the room, long-term recovery, you have to be connected into a community with relationships. We at ECTLC throw in work. You need work and relationships. There's the magic right there because of the purpose and that sense of self-confidence that you get. These are not protect, prepare, propel. These are not three separate programs. They are a connected phase of one journey. You move from one phase to the next. A person cannot prepare for a successful future when they remain in immediate danger. A person cannot propel toward independence without first having the opportunity to heal and prepare. And protection without a pathway forward if we give protection without the pathway forward, it could become permanent crisis management, which we have seen at times. Today, we're focused on protect. At future collaborative meetings, we will turn our attention to prepare and propel. Today, we will begin with our first responsibility, reaching people in crisis, protecting life and safety, and creating a real connection so they can get to the next appropriate level of care. One of the most important principles in this toolkit is no wrong door. Regardless of where someone enters the system, the door should connect to the rest of the continuum. That's why you're all here. I need you all. If we don't collaborate, Person gets help and doesn't move to the next step. The collaboration is needed. A referral is not a connection. Some of you that work hands-on, you know what I'm talking about. A referral is not a connection. You might have to spend days or years, sometimes to make it a connection. It's not. Giving someone a telephone number is not a warm handoff. Sending a name to another organization does not mean that the person arrived, was assessed, and received care. We need warm handoffs, navigation, transportation, ongoing human contact, but funding can be, no, I skipped one, and follow-up between programs. Technology can help us track those connections and improve accountability, but someone must remain responsible for ensuring that the person reaches the next level of care. We also need strong public-private partnerships. Government provides vital resources, but funding can be restricted, slow to adapt, and disrupted when policies change, which some of us in the room have felt. It's not fun. Philanthropy can respond quickly, fill critical gaps, support innovation, and invest in programs that demonstrate results. Together, public and private partners can build solutions that neither one can accomplish alone. San Diego has a remarkable opportunity before us, and I'm going to bring in my Imperial Valley and my Los Angeles over there too. Los Angeles has their work cut out for them, I do understand that, but there's an opportunity for all of us for sure. We already have many of the resources we need. We have great outreach workers. We have law enforcement teams. We have shelters. We have great healthcare systems. I think we get frustrated at times, but we forget what we have compared to others. It's amazing. We have a great, great system. We have enhanced care management. We have faith-based programs, community-based organizations, innovative technology, addiction and mental health providers, philanthropy, workforce programs, peer support, and housing resources, and anything else you can think of, we have. The question is whether we will continue to operate as a collection of good programs or become the national example of an effective continuum of care. If we collaborate, use our resources more efficiently, and establish clear handoffs, track meaningful outcomes, and accept responsibility for helping people progress, I believe San Diego, Imperial Valley, Los Angeles can significantly reduce the number of people living on our streets. And remember, when I say people living on the streets, yes, I want San Diego's streets back, looking good, property values going up. There's other things to consider here. Those are lives, people's dads, people's sons, people's wives, people's girlfriends. These are human lives out there on the streets, stuck. Not because they want to be, even if they say, I want to be. It's bigger than that. It's more complex. We can protect people when they are most vulnerable. We can protect them to rebuild their lives. And we can propel them toward recovery, employment, stable housing, self-sufficiency, and renewed connection to their families and communities. That is the vision. Today, we begin with protect. And as you listen to the presenters, I encourage you to consider not only the important work that each organization is doing, but how we can connect that work into one clear, accountable pathway out of homelessness. Thank you. All right. So we're starting strong, guys. We're starting strong. We're coming in with our district attorney, who I think is one of the most amazing district attorneys and puts her heart and soul into what she does and has a lot of outcomes. Today's about what San Diego does well, and it's about great outcomes. So let's welcome our DA, Summer Suffin. Thank you very much.
Luckily, I never learned the whole queen princess gesture thing, so I don't know. I like to do things for myself still, but it sounds like Hayden, you've got it, so I'll try to gesture. Hello, everybody. I see so many familiar faces. so many friends, so many collaborators that I've worked with, our office has worked with on multiple things. Dr. Julie Hayden, thank you so much for bringing this amazing group of doers together in one place right here in Marina Village. I really appreciate it, and I'm so honored that you're on the steering committee for Shelter Ready, which I'm gonna focus on a little bit. Before I do that, as all of us know, nothing gets done without an amazing team. And so everything I'm gonna talk about was not done because of that I did it. It's because my team rolled up their sleeves and worked with the community to do it, and I'm very, very grateful for that. You're gonna hear that the coordinator for Shelter Ready that some of you have heard about, but you'll hear more about, is Marla Kincaid, who's here with me. And many of you might know Marla from her years of work with PERT, and solutions that are brought for substance use and overdose that she leads. So I'm very proud to work with her. Also, Cameron Celeste, our Economic Safety and Development Director, is here, and our care center that was there that implements the one-day solutions that many of you are part of. Like a good leader, Rick Navarro left left his team here because we had some kind of crisis, and he didn't ask his team members to go. It's a sign of great leadership. He went to take care of it, but it's great to have Samantha Tamayo and Rob Bird here from the care team. So why is the DA involved in the issue of unhoused people and homelessness? Actually, it was way in beginning when I spent 28 years on the ground as a prosecutor, built a sex crimes and human trafficking division, but when I became the DA in 2018, I realized this very strong intersection between homelessness, between public safety, between mental illness, between addiction, how much of an intersection that is, and that our system is not always equipped to bring the best and most compassionate solutions to this issue. And we go to kind of a quick jail, prison, as opposed to all of the other treatment paths that can be available. So we had 200 people, some of you I see here, NAMI and others that were there at the table, and a blueprint, which you'll learn, believe in, that if you come up with good ideas, write them down, lock them in, because they have to become the thing that you work on so that you don't meet and waste everybody's time. So you'll find it on our website, the Blueprint for Mental Health Reform, addressing that intersection. And there we decided on some major points that needed to be done. One of them was in 2018, we had nowhere other than an emergency room where a family can take a loved one in crisis 24/7. Now we have 4 new crisis stabilization units, and there are 2 more in development, so that police can bring someone from one door to stabilize them, someone who may be in crisis on our streets, and a family can do that, and they can re-up their medication. We have a doctor on call, and so, I wanted you to know that because all of you are trying to help someone, and these were not available in 2018. They're new to our community, so people are still learning about them. But they are a great thing that I encourage you to go and look at. And as you implement your blueprints, there are people who are not going to be ready to go into an aggregate shelter before they get stabilized. You're not going to take them there before they begin their stabilization. And so these are available now, and they're really incredible, the stories. If you go, these people that work there are like heroes, the way they can talk to people and provide them with what they need. So we decided that there's something that was missing in San Diego, and that is the implementation of innovative technology that can connect all of us together so that we can leverage the power of each other. It just didn't exist. There was different technology solutions that different commissions had, different shelters had their own system, but at the end of the day, if we talk to the very brave outreach workers, they told us that they had sticky notes with their desperately held on contacts that they established a relationship with, where they would call and beg because they just got somebody on the street to agree to go into a shelter, but then 10 days later, they've lost the trust and they've lost that connection with that person that now was no longer ready again, because they're back in a cycle of distrust, a cycle of mental health, a cycle of addiction. Timing is everything, as you know, in life. And if you don't get it that moment, the next time you meet this person, they may not be there. Literally, they may not be alive and there. And so the outreach workers that we talk to, and a little secret is my superpower is listening. So it's about talking to the people that actually know that what is going on, the gaps, and then trying to find those solutions. So we wanted to do that. We also wanted to expand the ability to mandate treatment for those who desperately need it. And I know this is a terrible word in some cycles, mandated treatment. But I think, you know, my psychology degree helped because there's a lot of studies, I encourage you to look at them, that say that you have an almost even chance to help someone with mandated treatment and voluntary treatment. So if we can encourage someone to step their foot into treatment, we might be able to, they might want to stay, you know, once that happens. And so we did that through Prop 36. I'm going to show you some numbers. And then we wanted better legislation. And quickly, I'm not going to spend a lot of time on this, but I needed to spend money, asset forfeiture money, to do this technology and everything. And because I literally must follow every letter of the law, the rule of the law, DA can't, you know, can't walk on the edge anywhere. I needed to, even though anecdotally we thought there's an intersection between public safety and homelessness, I needed to actually get the numbers. So math is not my strong suit, that's why I went to law school, but we had an incredible senior intelligence analyst in our office that we stole from the police department, sorry, police department. But I have to admit, as a good Catholic girl, that, you know, when I steal something, so we analyzed the number of unhoused people compared to the general population and the number of criminal cases we have on both the victim side and the defendant side. Now, why could we do that? It's that you have only one DA's office. And this one DA's office is your people's prosecutor for all 18 cities, all 39 unincorporated areas, which means every police report on a felony that we file, we have ownership of it, and we can do this data, which no one else can do because they have just a piece of the puzzle. They don't have the whole picture. And so by doing that, next slide, we were able to capture this first from the medical examiner and validated that persons who are unhoused in the year 2024, and the reason I didn't include 2025, there's a little blue thing. All of you, by the way, can get this PowerPoint. The ones who can't see it, Julie, you're welcome to send it to them. There's going to be good news in 2025 on this number from the medical examiner. It's going to be released very soon on Overdose Awareness Day. But it was in 2024 132 times higher rate of overdose deaths for our unhoused population. That's astronomical, really, when you think about it. You're talking about total overdose deaths of 859, and then your unhoused are 284 of that. That is just really makes you cry, right? So this good news in 2025 that's going to come out is going to show a 25% drop in that of lives saved. So next slide. We looked at victimization on our street. You know, people are cruel to the unhoused. There's sadistic people that think that my office isn't going to care if they bash or beat or hurt someone on the streets. So they get out their sadism, their fantasies about violence on people who are unhoused. But we get them every single time. Message hopefully is becoming clear. But they're 64 times more likely to be murdered in San Diego, and 13 times more likely to be assaulted, robbed, 24 times more likely, and there's more on sexual assault statistics and other. Next slide. And then when you look at the rates of crimes being committed, the big highlight here is arson, and I think you know that. Encampments and everything bring, and my fire chiefs tell me all the time, this is a big risk. That's what they're responding to. And you can see arson 305 times more likely that our defendant in an arson case. Oh, by the way, this data only includes cases we charged on a beyond a reasonable doubt standard. So not just arrests, but charges. 305 times higher rate that it's going to be an intersection with homelessness. Next slide. So you can skip our mission. I'll talk about it on our way, but you could see why the DA is involved, because we added to our mission not just prosecuting crime, which is very important, ethical, fair prosecution, but the prevention of that harm if we can stop it. And so we skip this slide. During COVID, our victims of crime, you know, we're responsible constitutionally, Section 28. I have to remind the legislature all the time that victims matter also, and I have to cite the Constitution, Section 28. Our victims were getting the snot beat out of them because they're having to be stuck with their abuser. They had nowhere to go during COVID. So it was kind of terrifying. If they had a moment to make a call to get out of that human trafficking or domestic violence situation, we didn't have time to lose them by looking for if there's a shelter available, which used to be 10 days. So we used a nonprofit technology company called SoupTech in order to build a technology that allowed us to do a hotels.com, where we quickly match our victim with the right shelter. So that we're not sticking a mom with children in a shelter that has, you know, males or teenagers or something that doesn't fit. So there's a fit. And with this, we brought it down to 8 minutes at an 80% match using technology, putting all our shelter beds on one collaborative and creating a steering committee and working on it. After 5 years of doing this successfully, we asked the question, next slide, is could we bring, these are all the collaborators, could we bring the same technology to the entire picture of homelessness and all of the shelters available? And you know, I woke up in the middle of the night with this question. I called SoupTech and said, remember what you did for us 5 years ago, which has saved so many people? Could you envision doing this on a bigger scale and bringing all the shelters, all the people who are the outreach workers, and being able to use one app like a hotels.com and make a reservation to a matching shelter, so you're not sticking a disabled person, you arrive to the shelter, and oh, there's only a second-story bunk. So yes, they have shelter, but you've just let this person completely down. By the way, they're on the street, as you all know. I don't need to tell you, because many people have let them down. It's the story of their life, right? And so, so that you at least have a semblance of a legitimate match. It's just like if you have your pet and you have to call every hotel to find out if they'll accept your pet, instead of just going on hotels.com or whatever app and seeing that they allow pets or not, and being able to book a room that allows you to bring your pet. The same in this app. Next. So I'm gonna roll, I've teased what this is. This started, we brought all these great organizations, next slide, because we're not the experts. We brought all these great people to design what they wanted on paper. Do you see the stickies? And once they designed it on paper, the techie people created it. And I spent asset forfeiture money on it, because I knew if I went to anyone and asked for money, it's another 5 years, of begging and pleading. So we used some drug cartel money. It's good use, and that's what we did. Anyhow, so the way the shelter ready works is, and that's why I have a great team that protects me, because I piss off a lot of people every day, but it's okay. You guys like me, it's all good, or some of you. So what you do is, if you are an outreach worker, you just take these steps, the client agrees, you put it in the app, you answer a few questions, so it's not the final full certification, because you're gonna lose the client. And then once that happens, the app will pop up with available matching shelter to your needs, age, children, pets, whatever it is, disabilities is put in there, and then it shows you the available space. Then you make a reservation that's held for, depending what the shelter wants, 24 hours, 48 hours, whatever is reasonable to get that there. Next slide. From the shelter side, we wanted the shelters to include high barrier and low barrier and every kind of barrier. So they enter their own requirements and their own availability, so that we're not forcing anybody to do anything. And they also can enter geographic, like let's say only the city of San Diego is paying them, so it'll be geographic to the city if that's their requirements. If they don't want geographic, it opens it up to everybody. Next slide. And then all of this will go into a transparent data lake, and this data lake will tell you what kind of person could we not shelter, so that when we build shelter, we build to the true need and gap that's been established regionally through this app. Next slide. All of these people are currently using the app or about to use the app, meaning the steering committee is allowed them in and they're ready to start using the app. These are the shelters. Next is 3 pages of slides of all the outreach organizations that are either already using it or have been approved and are being vetted to use it. Next. This is how the app looks, very simple. Right on your phone. You don't need new technology. It's just a regular app like any apps you use, but just better. Next. Well, next. So there's a video, but we don't have time for it. If there was time at the end, we could play it while you're eating. So we'll go on to the next. I want to get to the final. There's a great steering committee, and lots of amazing people are on it. Lucky Duck, East County, 211, the school system, the seniors. So we looked at veterans, seniors, young people, like many homeless people in schools. All of these people are part of the steering committee to create the app, the Housing Commission, the Regional Task Force on Homelessness, et cetera. Next. And I thought there was so In the end, you can just go to shelterready.org if you haven't signed up to be part and get this app on your phone, and you'll get screened. I don't mean like screened like tonsil screening. I just mean like just to make sure that you're the right organization that can utilize this app properly. Thank you so much, everyone.
Exciting, right? So one reason I wanted her to present, because everybody needs to use it for it to work well. So if anybody knows how to spread the word on this, that would be great. All righty. For my next presenters, as I call you up, I want you to try to be concise because I want to move forward and have time for Q&A. So if there's something you can skip and save for Q&A, I think that's going to be a valuable piece of this. And for those of you that didn't know, there's 3x5 cards to put questions on. Where did they end up at if they bring them? Back in the back. So I have somebody filtering them. I said, be good. Get the controversial ones too. Okay. So next, we're going to have our San Diego Police Department Intervention Services team. We'll have them come down and join us. We've got Matt and Kayla. Okay, Matt, let's just say it. I'm not good at pronouncing names. I get worried. Botkin. All right, and we work with them all the time at East County Transitional Living Center. So again, this is all about showcasing what we do well. So we're super excited for them to share. And take it away. You'll have to share a mic and try to be as concise as possible.
All right. If we talk really fast, that'll be concise. That's what we do when we get nervous. So, good afternoon, everybody. Matt Botkin, San Diego Police. Oh, better? All right. I'm always worried it's going to be too loud. With the San Diego Police Department, RJ says, no, it's not too loud, so that's good. I'm a lieutenant in charge of the Homeless Outreach Team, Intervention Services Team, and a bunch of other things, but we're here today to talk to you about the Intervention Services Team. Really quickly, especially because we were told to be concise, Intervention Services, what they do. They work with high utilizers of police department services, fire department services, EMS, behavioral health, hospitals, traditional hospitals. We're going to talk to you a bit about why they were created, how they were formed, and the approach and how it evolved. But I'm going to hand it off to somebody who really knows what they're talking about, and that's Sergeant Kayla Evans. So here you go.
Hi, good morning. My name is Kayla Evans. I'm the sergeant for the Intervention Services Team. From now on, I'm going to refer to it as IST, just for simplicity, sorry. You guys want me to talk fast? I can't do it all, okay? Gotta read off a script. So IST really started on a much smaller scale. For years, the San Diego Police Department only had one officer who was dealing with our more complex cases. And just by happenstance, probably in October of 2024, maybe September, he just came to work under my umbrella of supervision. And as I was kind of taking a deep dive, looking into some of the work that he did, trying to get a better understanding of it, and let's be real, it's a very nuanced system, so it took a lot to learn, right? I quickly learned, it became apparent to me that a relatively small population was consuming a disproportionate amount of our resources. In fact, at one point, roughly 1% of the population we were looking at was responsible for approximately 17% of our highest priority radio calls. You had the stat that you had for that, didn't you?
Oh.
That's kind of hard with the mic.
Yeah, so just to, well, it's hung up on your gun belt, all right. Just to put that number into perspective, that's 1/5 of all radio calls coming from 1% of people, or 17 times the average number of calls for service that an individual would create. So a large, really large, steep amount.
And that wasn't just pulling from the police department's resources. That's also pulling from the fire department, from our EMS, from the hospitals, the jails, the courts, the whole justice system, right? And when you take a look at these cases collectively, you're talking about a significant operational and financial burden across multiple systems. And it's not just about, obviously, the operational and the financial aspect of it. It's also looking at, more importantly, like these individuals are repeatedly interacting with these systems, and they're not getting better, and they're not getting treatment. So that's kind of what became the concept of IST and like where we started. And we learned very quickly that just how time intensive these cases are. You can't just make a contact, one time, or hand them a sheet of paper with a phone number of resources and expect the problem to be solved. It's not going to work out that way, and we learned that. Many of these individuals we're working with have been cycling through these systems for years. They suffer from substance abuse disorder, mental health issues, homelessness, medical, you name it. And a lot of them are co-occurring. And we just, we realize it's going to take consistent engagement, follow-ups time after time, and someone who's not going to give up when the first attempt of a solution fails. So we realized that this couldn't remain something that was handled by one person, and we needed the ability to take on more cases and give the level of attention that they required. I'm sorry. Next slide, please. So just a little bit. And that's ultimately what led to the expansion of IST. And with that expansion, we became much more deliberate about what we wanted IST to accomplish. Next slide, please. So when we're talking about IST's objectives, the simplest way to explain it is that we're trying to interrupt this cycle, right? If you look, it's like kind of a revolving door. We're seeing the same individuals repeatedly going from the street to an arrest, to jail, back out to the street, calling 911, getting transported, getting released, and over and over and over again. And traditional enforcement may address what's happening at that particular moment, but it doesn't necessarily address what's causing that person to come back into the system over and over again. So we started looking at the cases from a broader perspective. How do we reduce that burden to patrol? How do we reduce that burden to fire, to medics and everyone, but at the same time finding a better solution for that individual? And so the reality is, right, there's no single answer. For one person, success might be residential treatment. For another, it might be housing and case management. And for someone else, it might be that their condition may be so severe that they need a higher level of care. So the goal of our team isn't simply to stop the calls, it's to figure out what is driving the cycle and what type of intervention we can use to actually have a chance of changing it. And so to do that effectively, we realized pretty quickly that this isn't something that is just a police solution. Next slide, please. So going to the expansion of IST, we fully went operational in September of 2024. So today it consists of myself as a sergeant, and I have 4 officers working for me. But if you look at the slide, you can see that it's a whole team behind us that we work with. A huge part of what we do is partnership. We work very closely with the San Diego Police or the San Diego Fire Department's Resource Access Program, the RAP team. We work with LIFT. We work with the city attorney, a multitude of other agencies and organizations. Because the reality is that police can't solve these cases alone, and really, we shouldn't be the ones solving them. But that's just kind of where we're at in today's society, right? So we try to do what we can, and what we can do is to identify these individuals, we build relationships with them, and then we try to help bring the right people together, because we find that instead of everybody dealing with one small piece of the problem independently, we're trying to create a coordinated response that we can all address it together and find a solution for treatment. And so by expanding the team, it gave us the capacity to do more of that work and take on more complex cases, while hopefully reducing the negative impact those cases are having across all of those different systems. So briefly, I know we're trying to talk a little fast, and that's really just the tip of the iceberg, what we do, but we do have a couple cases just to show you, just to kind of show you what we've done and what we've dealt with the past couple years.
Okay, so the first one, this first instance, and you can see it on the other screens, and I'll go through it really quickly without reading it all. So this first highlight is really highlighting what happens with consistent engagement. So this particular person had, over a 6-year period, created 163 individual arrests for themselves, low-level offenses, narcotic offenses, quality of life offenses, but 163 for one person over 6 years. I think there might be people in the room that don't have any, and there might be people who have a few, but 163 over 6 years is quite a bit. But with consistent engagement, with trust building and rapport building, that translated to this person entering treatment, actively participating in their own treatment, remaining out of custody to this day. And that is what we're really aiming for. So that's example number one. Sadly, though, next slide, sorry, bad with the mic. It's not an isolated set of circumstances. This next group of people, 4 clients that we had alone over the year of 2024 created 900 plus calls for service to 911 just by themselves, which translates to over $600,000 in personnel costs. Dispatchers, the medics that go out, ambulance, fire, everybody else. But by partnering with LIFT, partnering with RAP, and a handful of others, we reduced that call volume by 90%, which translates to an almost $550,000 in cost savings. And so the team, we focus on people, but the result also turns into resource and fiscal management, which is just, in this day and age, is super important. And I'll have Kayla cover the last two really quickly.
Yeah, I'll just go through really quick. This one's a really good example of why these situations really require a whole city approach. So this individual that we were working with was one of the highest 911 utilizer in the city. And every time they were calling, you had police department showing, fire department showing, and EMS. And oftentimes they were getting transported to the local hospital. So over time, the estimated cost associated with those responses is around $250,000 just on the city side. That's not actually accounting for the hospital expenses, right? Getting them admitted, the treatment, the staffing costs, all of that. And beyond the financial impact, there's a tremendous amount of time and resources being used by first responders and hospitals as well every time we got called. And more importantly, the individual circumstances weren't changing. They kept calling, they weren't getting the treatment they needed, and they had some pretty severe medical and mental health stuff going on. So this became a collaborative effort between RAP and LIFT and the city attorney's office, and with each one kind of working in their own roles, we were able to come up and find a higher level of treatment for this person. In this case, it was an LPS conservatorship, working with the hospitals and just kind of getting them stabilized and getting them the help that they need. The result was a better long-term outcome for the individual while also significantly reducing the repeated demand of emergency and city resources. Next slide. This is probably one of my favorite examples just because this one really brings us back to the person behind all the numbers. We had worked with this person. He came on our radar, I think maybe by patrol, and he was a severe substance abuse, chronic alcoholic. Often, just to give the Cliff Notes version of it, was relapsing quite a bit, constantly in and out of the hospitals, getting transported, calling for medics constantly. We were able to establish a really good rapport with him, and it wasn't a streamlined event, right? It wasn't easy. A lot of relapses, not a straight line. Relapsed quite a bit, a lot of setbacks, but at the end, he actually ended up getting into treatment. After we built a lot of trust with him, he had relapsed at one event, and we met him, picked him up, transported him, and he stayed in the program. He got sober. He moved back to, he moved back to his home state and was with family, and he got a job, and he's stable now, and every once in a while he'll reach out to us, and he's thriving and doing really well. So it's kind of a nice inspirational story for us that we really like the happy ending with. And so when we talk about reducing calls or saving resources, those things absolutely matter, but this is what ultimately we're trying to accomplish. So that's it for us, I think. You got any questions, or you have anything else?
Yeah, just a final wrap up that I think Kayla kind of hit at the end. So obviously, for all of our collective professions, right, people are really the priority for us. But similar to what the district attorney hit on, the justice system at some point morphed from moving away from a suspect-only focus to victims and the community and also the suspect. And so for us, it's important to highlight the people side of things, but there's also the appropriateness of highlighting the positive impact to the community and to the people that are calling us, that we're working with, are affecting. It's also right to recognize this impact that this kind of team can have, the approach that they make towards safeguarding resources and finances for everybody. And the money that was saved by us not responding, the money that was saved, and the resources that are saved really are kind of hard to track. But in this case, we tracked a couple of them. People show up at a hospital, they have to wait a really long time. Not when we can slow down this exorbitant use that some of these people are creating. Calls for service, those can be answered more quickly. There's a lot of ways that this spreads out. And so the people matter 100%. They're always first. But the finances and the resources, those matter too. And when we can hit all three, it's really a bonus. So I think we'll do questions at the end, right? So no questions. Thanks very much.
It's a really great point. That efficiency does give that funding to utilize it everywhere else we need it. So it is an important piece, even though we ultimately care about the human. Okay, Very excited also. I mean, I think I just picked all my favorite people to speak here, right? So we're going to bring up Drew Moser from the Lucky Duck Foundation, and he's going to share some success he's had with public-private partnership. And I think as much as I'm excited about the toolkit, all the changes, there might be gaps, and we're really going to need what he's done well. So I'm very excited to have him share. Thank you, Drew.
Thanks, Dr. Julie. It's not what I've done, it's what Lucky Duck has done through our board and donors and partners. It's a great group of people. For those of you who don't know who we are, our mission is to prevent and alleviate the suffering of homelessness throughout San Diego County. Our co-founders personally match donations up to $2 million per year, and then we do basically one of three things with that. One, we have our ongoing Lucky Duck Foundation programs. Jen Weck and Carlos McRae from our team are here and oversee some of those. Two, we provide resources for strategic collaborations. And then three, we try to be a convener and a thought leader in the issue of homelessness. And if we need to, push on local government to try to speed them up. That's frankly the most challenging part. But one tool that we have is something called Shamrocks and Shipwrecks. It's a scorecard meant to grade political will and effectiveness of elected officials across the county. Good actions get shamrocks, things that absolutely can and should be replicated across the county. And inaction or ineffectiveness gets shipwrecks. Our DA, who presented on the Shelter Ready app, it's a great practical strategy. She's an elected official, and not too long ago she got a shamrock for Shelter Ready. So I'll try to be concise. What I'm going to cover is that middle category, or that second bucket of strategic collaborations plus resources, which oftentimes comes down to political will and partnering with local government to activate tangible strategies. And then we'll come alongside and provide our precious limited philanthropic resources to help kickstart something. So if we can start with the next slide. So these are bridge shelters. These can come online within months for literally pennies on the dollar compared to the cost of adding housing. Housing, I think we can all agree, it's maybe an ideal outcome when folks are ready. But frankly, it's years, if not decades away, and it is really challenging to scale economically. When you're talking about $500,000 plus per door, it's incredibly costly, and it can be akin to fighting an active wildfire by planting more trees. Our view is we need to get the wildfire under control now, help people move inside and start the process of putting homelessness behind them. And then ideally they can find a more long-term strategy. So these, Lucky Duck owns two of these. This particular one is located at 16th and Newton, sleeps over 300 people per night. Again, it can come online within months. It's certainly within reach to scale this thing. We would put one of these in every district if there was the political will and the space to do so. This particular one is done in partnership with the City of San Diego, who provides, through the Housing Commission, the operating dollars to bring in the Alpha Project to operate the space, help people move inside, and find a brighter pathway. This is something called Harbor Tay that we just activated within the last month. 34 rooms, 54 beds for youth, transition age youth, ages 18 to 24. We prioritize youth and we prioritize seniors. About half of the chronically homeless population suffered from homelessness as a youth. Okay, so it's a critical time, at kind of an inflection point where it's like one provider says, if we can catch kids while the cement is still wet, we can totally change the trajectory of their lives. And so this is a partnership with Urban Street Angels, a credible youth service provider, the County of San Diego, and the Regional Task Force on Homeless, who will provide the operating dollars to cover the staff for the housing navigation, the employment navigation, to help young people move off the streets. Lucky Duck provided the startup capital Just like the bridge shelters, I didn't mention with the bridge shelters, we purchase those assets, we cover the cost to construct them, and we maintain ownership of those assets. In this particular instance, they needed startup capital to hire the staff to do a nominal amount of renovations, to provide the move-in kits, et cetera, so that the doors could open as quickly as possible to help young people move inside. About 100 youth, just shy of 100 youth, will be helped per year through this particular strategy. We're calling it Harbor Tay. It's on Harbor Boulevard, and Tay stands for Transition Age Youth. Genesis Recovery, that was, about a year ago, I think we activated that one. In part, well, largely because there was only about 100 detox beds in the entire county that accept Medi-Cal. Okay, so it's really, really challenging for folks that have substance abuse challenges to get the help that they need. And when we talk about folks who have been there, done that, put life on the streets and addiction behind them, and you say, well, how many people are struggling with addiction who are currently unsheltered? The number we hear most frequently is 80%. And so this thought of thousands of people on the streets, several, a significant number struggling with addiction and substance abuse, accessing 100 detox beds, it's a bad math equation. And so through Genesis Recovery and the leadership of Dr. Julie Hayden, we were able to provide a matching challenge to help kickstart these beds, where we said, we can give you, I think it was about $350,000. She went out and found that amount and a little bit more to then bring these beds very quickly online. 24 beds that then ultimately the county will help provide the monetary resource to operate those. But already there's been a boatload of success stories that have come through that. And bottom line, there still needs to be a meaningful number of detox beds added to the system. And much like the previous two examples I've given you, we're fully prepared to bring our philanthropic resources to bear to add that capacity. And then I think this is the last one. This is Vista. This was also about a year ago. Another transitional housing project for youth ages 18 to 24. This one was done in partnership with the city of Vista, where they actually purchased that home. And same thing, we provided about $250,000 of startup capital to activate the space so young people could quickly move inside, so that the staff could be hired, and so that the effort could get off the ground. It's already helped about 40 youth in the first year, and we'll look to do more of these types of strategies. So those are just a few examples of what a public-private partnership, a successful one, looks like. We certainly don't have all the answers, and I should also say none of those are perfect. The late Peter Seither, late owner of the Padres, you would say there's nothing perfect in homelessness. But if something's 80% good, we should act on it. And so you can shoot holes in those examples all day long, but the bottom line, they're urgent, they're cost effective, and they help a meaningful number of people move off the streets and find a much brighter pathway. And that's very much where we operate day in and day out. So happy to answer questions at the end, but it's great to be here with you all, and very much appreciate Dr. Julie's leadership to bring us together.
Very good. Yeah. Even in all we've done, we put our life and soul in. It's easy to poke holes in what we do, but the point is not giving up and keep doing better. And that's what we're all about. So we're going to keep doing that. Okay, I'd like to have, again, Lisa, is it McFan? Because every time I go to say a name, I forget I haven't practiced pronouncing it. Oh, is Lisa not here? Matt. Come on down, Matthew and Jorge from Serene Health. They're going to share. They might share about their services and what they uniquely bring to this protect stage we're focused on today. But what I love about our organizations working together is we go, can you help? Yes. Can you help? Yes. Whatever we do, we go, yes. And we move forward together. And that has been fun. And we've done way more together than we could have done separate. So that's what I'm hoping comes out of this collaborative too. So come on down and share a little bit about Serene Health. We'll have a lived experience right after this, and then we'll have some time for Q&A.
Thank you so much for the great introduction, Dr. Hayden. So my name is Matthew Motti, and I'm our Director of Enhanced Care Management at Serene Health.
Good morning, everybody. My name is Jorge Medina. I'm the Director of our Community Supports Program here at Serene Health.
And it's an absolute pleasure to be here in this room with so many impactful drivers of change and hope in the community. This really is the it takes a village mentality to combat this issue that affects so many of us in the community. So really just want to say it's an honor to be here and get a chance to talk about Serene Health Group and what we do. So we're a population health company. So essentially we deal with, like so many people in this room, individuals who have complex lives. We don't just focus on one item. So it's everywhere from clinical healthcare to housing, behavioral health, psychiatry, medication support, community resources, all wrapped around one person. So really taking somebody that's barely thriving, barely existing, and taking them all the way to thriving. Next slide. Awesome. And so how do we do that, right? We come across so many individuals, whether it's somebody that's transitioning from incarceration or somebody that's dealing with homelessness or substance abuse or psychiatric or behavioral health concerns. How do we get that person whole? And that's really part of our ecosystem. Those are different services we have. So enhanced care management, that is a Medi-Cal benefit, which is really complex case management. It's the most intense level of case management somebody can receive. And then there's community supports. Our main focus of that is housing, the housing trifecta or housing support, really transitioning somebody away from homelessness and getting them into stable housing, as well as behavioral health and psychiatry. But on top of that as well, we offer PRTMS, and we won't go into the details of that, but that's really a non-invasive way to address brain health for somebody that's dealing with trauma and substance abuse. So how do we do that? How do we become that bridge, taking somebody from crisis and bringing them to stability? First, that's finding them and building trust. So that could look like street outreach. That could also look like Dr. Hayden just mentioned, getting a message, we have somebody that needs help and can we do it? So that's encountering individuals, whether it be from the street or we have partnerships with police agencies or incarceral facilities, and really getting those people where they have the highest need. And we get them and then we stabilize their basics, right? So what does that look like? That looks like somebody who maybe hasn't been to a primary care provider or gotten lab work or checkups done in 2 or 3 years. And so we'll get them a case manager, we'll get them dedicated and tied into that, or they're really just lacking basic support like food or medication. And then maybe again with housing, and I'll have him expand on the housing.
Yeah, really we focus on building that trust. A lot of our members that we face and people that we face in the community struggle with a lot of broken promises. And the first step is really building that trust, letting them know that we're here and providing that support. And we interact with our members weekly, if not more, depending on the situation, advocating on their behalf for benefits that they may have been denied. Really focusing on where they're at, coming up with an individualized housing support plan, and following through with short and long measurable goals that we can follow through. And they can see that progress, because when they see that progress and those little wins that start stacking up, they know that, okay, we have someone here that's following through for me, and they're supporting me, and they're taking me through the steps that I need to get taken through to get to that next level of better living and having that support. So we utilize the CalAIM program to really spend that time with our members. There is a housing deposit support as well that really helps them as well get to that next level when they are struggling maybe paycheck to paycheck. So we see a lot of unhoused members as well as families is going through housing insecurity. So we, again, figure out where they're at, work with them to really get them stable, whether it's also, like Matt said, food insecurities, clothing insecurities. So we address all those factors and really find that program or that piece of that puzzle that they need to get to that next level so they can continue to compound on their success on those goals.
Awesome, thank you. So, once we encounter the individual, right, we're finding, building the trust, we're stabilizing them with the various, items like housing, food support. But then there's also too, how do we heal and how do we move forward? So that's kind of a deeper and more complex level. So those are things like substance abuse treatment, psychiatry, trauma support, education and family reunification, workforce development. So we're really taking an individual who comes to us really disconnected from society, oftentimes disconnected from a lot of the support services they need, get them that support, stabilize them, and then take them to thriving, becoming productive, meaningful members of society. And this is really focuses on the it's a one member, one team approach we have as a population health company. So when we encounter somebody, there's so many open chapters and so many unaddressed needs that have accumulated over the years, and that's not really something one caseworker or one case manager can do. And so what do we do that? We come together as a team, and when we do that, we have to listen to the individual. We have to understand where they've been, where they are now, where those gaps are. And then once we do that, we come together and we develop a plan that could look like a care plan, a treatment plan. But that's one plan that we come together as a team and we coordinate. And then how do we do that? We connect that. So we're merging somebody that has clinical needs. So we have a team of RNs that work and support the members that have individual or complex clinical needs, but also the non-clinical needs or those social determinants of health. And we're bringing those things together. And when we bring all those together, that's how we achieve stability, is really looking at the person as a whole and bringing together not just the fact that they're not seeing the doctor, but it's also the fact that they haven't been linked to behavioral health, they haven't been linked to psychiatry, they need substance abuse treatment, but they also need housing, and they also need training and workforce development. So it's putting all those things together to help bring a person whole. All right, next slide. And that's really, when you look at the overall impact, that's how it happens. Because when we're changing one person's life, and you look at maybe it's a mother or a father, and you're bringing that person stable and whole, that's changing not just their lives, but it's also changing their kids and that family's life. And when you change that family's life, you're now changing the community. And that's really the big focus, is it's stopping the cycle of abuse, it's stopping that generational trauma. By treating one member at a time, you're really changing the family and then changing the community. So a lot of the things that we talked about, right? Doing street outreach. We have dedicated teams that are all throughout the community, different encampments, shelters, and various resources, encountering people that may need help and getting them connected to those resources, whether that be, getting them connected to housing support, and getting them tied into shelters, but it's also dealing with our clinical team, educating them on their chronic healthcare conditions, helping reconcile their medications, making sure they know when to go to the ER, when not to go to the ER, when to go to urgent care. But it's also dealing, we have a big focus on dealing with the justice-involved population. So we're meeting members that are just about to be released from incarceration, and also people that have been out of incarceration for some time, and really working to keep them back in the community, helping develop skills so that we're developing healthy habits and not ending back into incarceration, getting them tied to substance abuse, psychiatry, and therapy. And a big part of this is, like I mentioned, the workforce development. And this is why we're really lucky and blessed to be working with Dr. Hayden and Rhombus, because it's really important as we're trying to not just change one person's life, it's also changing the community. But we need people to do that, right? So we need skills like community health workers, peer support specialists. And the best way to do this is through lived experience, because how am I going to trust somebody who hasn't been through what I've been through? And this is the best way we do. And we've already been able to do this with a couple individuals as we've been working together. And those are really the best way to change the community, is somebody who's been there and done that, and they're able to drive that change in the community. So all of you, if you have individuals that come across your organizations, that could benefit from things like psychiatry, substance abuse treatment, care coordination, housing, we have a booth down there. Go ahead and please visit us, and we'd love to be able to work with you and help treat your members. And then lastly, what we just talked about, right? It's one member, one family, and one community at a time. It's integrated. We're not just looking at, getting somebody connected to a doctor, but we're also looking at developing life skills so there's a lasting impact in the community. All right, that is it for me. Yeah, thank you.
Thank you. Are you seeing the themes here, everyone? So we're modeling what San Diego is getting ready to do, that collaboration. Okay, one more speaker, and then we'll get to Q&A. So we'd like to bring it home where it comes alive with a real human that exemplifies everything we've just talked about. So we're going to have Keith Cofield. All right, I got that one good. From We See You San Diego, they also probably have a booth. If not, make sure you get to know about their organization, because they're my favorite format of outreach. They do a great job, and they really make sure people they hold their hand the entire time through the levels of care. So I really appreciate We See San Diego, and we'll hear from Keith after Ken does something.
Magic tricks? No. If you have a question and you put it on a card, we're going to have Corey, Trevor, or Edward on that side grab cards from anybody. On this side, John or Sarah. We'll bring them back to Christina, and then we'll bring them up at the end. Thank you.
All right. Thank you, Keith.
Cool, thank you.
You got 8 minutes.
8 minutes? Okay, I can try that. Or 8 or 6 to 8. Okay, we can do that. 6. We'll go 7, maybe. So my name is Keith, and I work with WeCU San Diego, and I actually am a product of WeCU San Diego as well. My homeless career, I'll call it, was 12 years long right here on the streets of San Diego, most of it in Pacific Beach area and in other various areas. I have an intimate relationship with the San Diego Police Department. That's seen those guys a lot. They generally as transport to my other good friends, the San Diego Sheriff's Department. So, but I've gone through a lot. Nobody wakes up and says, I think I want to be homeless. I think that'd be kind of cool. But what I've found going through like my own processing and going through with WeCU through programs is that trauma is really at the root of most of addiction, and addiction is definitely going to be a big root of homelessness. And so it's kind of like a downward trajectory that you kind of end up at. And so for 25 years, I was addicted to opiates. It started kind of early in my life due to trauma and just like numbing and trying to get away. And then about halfway through those 25 years, it was unsustainable to maintain any kind of housing for myself, and I wound up on the streets. And like a lot of people wind up on the streets, and then they come to San Diego because you're running from something. And if you go south as far as you can, and you go west as far as you can, you wind up in San Diego. So we have a bunch of people out on the streets that share that same story. They're just from other places, but they are out here. But I didn't know what to do about it. Like I remember walking around on the streets and just being like, does no one care? Like, I mean, like I feel like I'm a human that people should care about, but I don't feel it. There is a large community of people that like to harass homeless people out there, so you do end up like in this like really isolated place. In 12 years, what's the PC term? Experiencing homelessness. I can promise you I've experienced every facet of homelessness you can imagine. And so in order to get like that privacy that you need, you end up in these riverbeds, you end up in these places that are like places that you wouldn't see yourself normally, but you're really just trying to get like isolated and alone just because it's shame, really. It boils down to shame. And so ultimately what's going to solve all that is not like just get them in a Medi-Cal program. Like you really have to address that trauma, and like it's not always medical. I want to honor you, and I want to talk about mental health too. A lot of the mental health that I've seen from my experience on the streets is not mental health that's like uncurable or a pill can fix. A lot of it is going to be fixed from addressing the trauma, letting someone know that they are a human being, that they are okay. Welcoming them into community is going to be huge. Community is probably the biggest step. It was the biggest step for me, and I analyzed data for WeCU, and from what I've seen, most of the people who do well is because they've really embraced the community side of it. So getting people around you who love and support you is going to be a huge step in the right direction for anybody experiencing homelessness. Whenever I wound up on the streets, what got me out ultimately, because trust, I know trust was talked about, there's not a lot of trust out there. You really can't trust anybody. So what worked for me and what made me finally say yes after all these failed attempts at Medi-Cal programs and things was I ran into a lady who worked with WeCU. Her name was Candace, and I knew her on the streets. She was not a good person. I wasn't a good person either, so I'm not knocking Candace, right? But we were I guess frenemies, like nice to each other's face, but like constantly stealing from each other. But I knew her, right? And so I ran into her at the alley at I think it was like Jewel and Ingram and PB. And I saw this lady that I knew and didn't like, but I saw that she was different. She looked healthier. She looked better. She had a Sprinter van, and I'm like, where did you steal that? But she's like, no. She's like, I'm not homeless anymore. I'm doing good. And I'm like this is a lady that I did not think could do good, at all. And so I'm just like, well, what's that look like? How did you do that? And she told me about WeCU. And she, at the time, I was detoxing real bad from fentanyl. And she wrote her number down on a piece of paper. and like an idiot, I didn't call it. And 2 weeks went by, and I kept that number. I kept it in my pocket because it was just something about her. And so I got arrested for a violation of probation, because who has time for court dates when you're on the streets? And when I was in jail, I made the decision to cold turkey fentanyl. I was doing about an 8-ball a day of fentanyl. And when I got arrested that time, it was May 5th, 2025. And I made the decision. They were like, "Do you want Suboxone?" And I'm like, no, I don't. I'm done. And it was horrible. So the detox process was really bad. It was mostly done in holding cell floors, which was just the most miserable experience of my life. But it put a really bad taste in my mouth for fentanyl, which I thank God for that. And then when I got out, I called Candace, and she had me meet her at OLOT. And then I went directly to Green Oak Ranch up in Vista, which turned out to be a place that I surrendered to Jesus Christ. And that was a huge step. And so after Green Oak Ranch, I went to another discipleship that while I was there, I was offered a job with We See You. And I work with them currently today. My life is dramatically different. I love my life. Thank you.
Thank you. So that's what it's all about, guys. People can pull out and live a good life. And we need all of the roads to help them get there. And then once they're on the road, we need to help them get to the next step. And that's what I've appreciated with We See You San Diego. One of the things they do, besides the dinners, they have the dinners where people can come, which is a great way to build that trust. They also raise money so that if somebody needs detox, if they need residential, if they need housing, whatever they need, if they're really ready and there's a barrier, they're going to make it happen. And they network all over San Diego, anywhere they need to make sure that person gets what they need, no matter what. And they have a good gauge of who's ready. And when they see that light in the eye and they know they're ready, they're going to make it happen. So I appreciate that heart, and I think that's one of the things needed. So we're going to go ahead and switch gears to some questions, and I debated on how to do this to make use of time. So I don't know if it's really going to work. We'll see if I read questions and this works well. Yeah, or you could read them because you've practiced them. Just come on up. You can come on up with me, and I'm going to and then we might gather others in the room to answer some of these questions.
I practice really hard questions. She doesn't know. These are my questions. Nobody else knows that.
You're not allowed to. That's cheating. Okay, go.
Will we get these slides, and how do we connect with Serene Health?
Okay, well, that's an easy one, guys. You gotta pick harder ones for me. So yes, I don't mind giving these slides. So whatever I have, and if anybody disagrees, tell me fast. Anybody that wants to email, you've been getting emails from us. If not, before you leave, make sure you have our contact. All our websites will get you where you need to go. You can join the Homelessness Solutions Collaborative, and then we'll get you everything we do. We'll make sure that you can find out about it. And then Serene Health is over there. They're staying for networking, but you can see how that resource is sitting right there for anybody to use. And that's what this is all about, letting people know about the resources.
When do you think the focus changed from housing first to treatment first?
What do I think about it, or when?
When did it?
Oh, when did it? Well, I don't even know if it has. I think that's the goal from the federal level down. But, we have a couple things happening there, right? We have what the federal government decides and wants and pushes, and sometimes funding's tied to that. And then you have California that might have different views. You have San Diego that might have different views. So I think we'll see some back and forth happening, which I'll give you one example. There was a NOFO, Notice of Funding Opportunity, put out for housing, and it represented the toolkit where instead of just housing or permanent housing or interim housing with no requirements for being clean and sober, no requirements for work or things like that, that would typically come, this one was very different. First time it unfolded, they wanted 40 hours required for getting benefits that were coming. Then there was, litigation. Then they came out with 20 hours required. So everybody applied. Everybody's excited. Nope, stopped. You know, there's litigation happening. There is no funding opportunity yet. And they're going back and forth, back and forth. What is it going to be in the end? So some of those things may delay what we see as like a application because of funding of treatment first in our programs. So I think we can jump the gun and move in that direction. And it doesn't mean you have to agree with everything in the toolkit, but I think big picture, San Diego can understand the pathway. So people need to get help when they're in their emergency situation. Not everyone's able to cold turkey on a jail floor, you know? Now, I have heard if you do that, your chances of staying clean and sober are higher. That's anecdotal, not research-based, but I've heard that. But, you know, I definitely have seen those that have appreciated, you know, detox and Suboxone and other kind of factors. So if we want to jump ahead of what's required, we can. And we can build our pathway we want. We can build what we say is that quality, effective, individualized treatment today. So I think that's what this collaborative will be about, is inspiring this to happen, for us to take charge, pioneer it. It's in a book, a binder, you know, stapled together. That's not application. We can decide what San Diego is going to do with what it looks like, creating that pathway for people.
Is there housing or shelter options for arsonists, sex offenders, or other non-legal residents?
That is definitely not an answer. I'm going to try. Maybe others in the room want to answer certain pieces of that, but I will say what I know. I will say there's a huge need for housing for sex offenders because nobody wants to house them. So I have housing all over the place, and that's a constant difficulty. People are saying, do you have any for sex offenders? And actually don't even mind having housing for sex offenders or treatment for sex offenders, because I have watched human lives change. Not everybody changes, but actually there could be effective intervention for certain things that we might not think there is. So we've got to have solutions. So I would say those are going to be key areas that are difficult to find right now, and we do have to have them. We have to come up with something, but I don't have statistics or data fast for that. And nobody raised their hand to answer that question.
This is for the San Diego Police Department. What were the majority of the 911 calls from the homeless pertaining to? Is there anything that you could, is there anything you could respond to that?
Yeah, typically they were calls for them either to receive medical treatment. That was the majority of them. They had some kind of a medical treatment they thought they needed. Most of the time it was not realized, and that brought ambulances out, which tied everybody up.
Okay, so if you didn't hear that, it was medical issues, but there might have been a mental health component or some other factor, addiction component behind it. So they thought they needed medical, so they're calling and getting that medical intervention. What
do you contribute to the 25% decline in deaths due to overdoses? Like, what reason do you think there was a 25% decline in death to overdoses?
So with the DA, you were talking about, we're going to see a decrease the next time we get a PowerPoint slide of 2025. What were some of the reasons for that decrease?
I can't tell you all the reasons, and I want to make sure the medical examiner has the report out, but I can tell you that since December 18 of 2024, so essentially 2025, 962 people that had long histories of drug use, hard drug use and addiction. Because of the treatment mandated felony, the Prop 36 962 went through a treatment track. So, and many, I've been in court to see this, many clearly intersect with homelessness. When you're there in court, you could see the judge saying, if I release you, do you have somewhere to go? No, they don't, the usual. And, I want to thank our county behavioral health because the state didn't provide funding, but they were committed. With the court and the DA, public defender, everybody came together and were committed to do our best to cobble together the treatment. And 331 went through treatment through the probation department. So they had other cases other than the Prop 36. And so they went through the the mandated treatment through probation. So that's a very large number that our drug courts were drying out. There were not enough people in them. So to see the infusion of treatment that people were participating in, I don't know if it's the whole answer, but it's part of the answer. It has to be.
Why don't you keep the microphone, because this next question is also for you.
Okay.
What is the right organization for the Shelter Ready app? Like, who should use the Shelter Ready app?
You know, anybody who provides shelter should use the Shelter Ready app. There's very because what the rescue mission, Catholic Charities have told us is it's reduced their work from 40 hours to 15 hours, allowing them to focus on the harder cases to work with. And any outreach worker that is part of an ethical organization that's out on the street trying to get people shelter. And as you well know, many of the shelters also have their own outreach workers. So what we're trying to onboard the maximum number of people. It is not, the steering committee makes a decision, but it's not one like based on, like, do you have gold stars everywhere? It's whether you're an ethical organization that is trying to do good.
And some of these questions we can give out answers in emails back to you with links on how to, we're definitely have a link on how to get to be a part of Shelter Ready.
I'll ask this question in regards to our hub. How many calls do you respond to on a month-to-month basis, and do you notice these calls come from low barriers?
Okay, so we started a hub actually partly or all through the Grossmont Healthcare District. And Skylar, I haven't seen you all day. I know you're here hiding. But do we have numbers easily? There he is. This will just be ours because 211, you can imagine, is off the charts. This is just ours. We didn't even advertise it, really. 30,000 calls in what time frame? For this year so far. July. So that's people, housing, addiction, mental health, kind of a mixture of all. Housing's the highest one. And so that's just us trying to help. And we wanted that for our own navigation, get people in, that initial call. And so it was way more than we ever expected. So I'm sure organizations like 211 that have call centers, I think we would be shocked at how many people. I also just give you one stat that just tells you where we're at. We have over, I think it's 600 now, families on a wait list. Homeless. That's insane. We got to do something quick. And so I can't, sometimes bring a lot fast. What I can do is coordinate better. So that's where I'm going now. Us collaborating to make more use. Now, I will say, and this is just a plug, but I want you to know about it in the future. A lot of us work together on a day-by-day basis as well. We have 2 houses we're hoping to get remodeled. That'll bring on anywhere from 40 to 60 more beds for women and children. Some of those in the TAY population. We've got a huge property. You can see the video for over here in Boulevard. Yes, it's in the middle of nowhere. Sometimes that's great. Might have 200 beds, real large location. And the cabins people, where are my cabins with a Z? Switzerland, they're bringing some new ways to do, the tiny homes scenario. And so we have a lot to go through before we can add those, but we might get 20 more cabins, on one of our existing properties through them. So we're trying because the need is off the charts. We've got to do something quick. So I don't know about call center, but the need of the humans that need places is just really a problem right now that's exponential in the last couple months.
This isn't being recorded. It's not Switzerland, New Zealand.
Wow. I just made that up. Good job. I'm worried about pronouncing names and I go different countries. Ay, ay, ay.
We're going to use this as the last question. And if you didn't get your question answered, you can come up and talk to us later. Hospitals release and send people back onto the streets. Is this going to change?
Is this going to change? It's interesting because we just had, what is the name of API now? East something. So the hospital that was private, API, was taken over by UC San Diego. Anybody know my answers here? Give it to me. Scream it loud. UCSD East Campus. Yeah. And then I saw, quickly, another hospital possibly coming in East. Do you know what I'm talking about? East County might have another hospital somewhere. We're working on it. So what we can say is everybody knows we need this, right? We know that. So I do hope that improves. I think the need is obvious, so let's see if we can pull some of this off. But right now, because you remember, I had the privilege of working with Dr. Ronit Lev, and some people in this room know her because she was at ERs in San Diego before she was the chief medical officer of the White House. So when she came for a tour, we talked about this, and she knew she was one of those, sometimes sending Buddy to the streets after they're in the ER. Because there's literally no other option. She had a heart. She knows that's not best. She wants to put him into a place, and there's literally no place to put him. And so she would do it. So at the top level, the leaders in this room, everybody knows that's not what you want to be doing. And so having the actual beds available is a big problem, what Drew was talking about. And then also that coordination. So if there's a bed sitting there empty and nobody knows about it, we've got to fix that. And that's Shelter Ready's on track. You can see the starting points of everything. And I've done a lot of things that started with nothing and went to something very big and very great. And it was slow and steady. It's just you race as hard as you can. And then when you stand back, you look like you're barely moving. But it works. We've often talked about, sometimes you get positional power from the top down. You have the authority to make change, and that's fantastic. And we hope those in authority do a good job with that. I've never had a lot of opportunity like that. It's always been from the ground up. So it's drumbeat. You just put the word out there. You start using the language, putting the needs out there, doing what you can do best. Man alive, what you can do with that. You can, little by little, make huge change in your community. 1 person, 10 people, 30 people. This is real. I've watched it happen. I know it's real. Those in this room, you're amazing. You're already, some of you, at the top of your game with authority and power and resources. And everybody together, we can do this. So I hope this collaborative continues. We're going to be putting this on. I hope you come. I hope it grows. We're going to already outgrow this place. I would like to keep it here. I love the parking. I love the view. So maybe switch buildings. But we're going to keep trying to have this happen where you have a place, and I want you to invite others, and we're just going to drumbeat. We're going to look at it, we're going to stare at it, and we're going to watch it improve. And we're going to remember in 10 years from now, when we have 0 homeless on the streets, remember where it all started? And we wondered if we could pull it off, and we wondered if it was possible, and here we are. So that's a vision I think we all share. Everybody coming here today probably shared that vision. So I'm just reminding you of it. When we break, I hope you keep the resource networking happening. I hope you get to know each other. All of you that are here, I know you have amazing skills, resources, a mind to share with each other. That's where the power is going to come. If you go to the booths over there, get to know who we have. If you want to have a booth next time on the table or somewhere, I don't remember. Go to Christina for anything that I forgot. But what we do is we get sponsors to help. I just don't want to have this without good tacos. So it's tacos and gorditos, right? No, I always say that wrong. Say it again. Tacos. I'm looking at my husband because what's the name of the gorditas? Tacos and gorditas. They're the best, So if you want to sponsor any piece of this, Serene Health has been gracious both times in a row to get the location for us. So we don't mind doing it all. We have some great help. Back in the back, I'll just wave. We have people that are in a program right now, participants volunteering their time. Yeah, for you guys to have a great event. that's what it's all about. Is they are getting experience, but they get to have this. We get to have this happen for you. So we don't mind all of that. We just don't want to go in the hole. Everybody knows how hard it is out there for our organizations. So if anybody wants to sponsor just like a certain piece of this for the future, we're going to keep it going. We're going to do February. Is going to be the next time. The reason for that gap is not because the need's not sitting right in front of us, but working in nonprofit organizations, you know how the holidays, you just got to skip them all. Like it just is a very difficult time. So we're going to go to February and we're going to meet back here and we're going to see where we're at. I hope you all work together in between them to push it along so we can see the changes we need. So if anybody wants to stay after for more questions from any of our guests that have come, please go see our vendors, and thank you all for coming.